Hello everyone, I am honored to present the result of our research on behalf of the co-authors. My name is Hyunsuk, currently a radiology resident at Seoul National University Hospital. The title of our research is AI-based identification of normal chest radiographs. It is a simulation study we've conducted in our multi-center health screening cohort. Here is the conflict of interest that I would like to disclose. As you know, chest radiograph is widely used as the initial workup for various respiratory or cardiac symptoms. Because of high volume of chest radiographs in most hospitals, there is a shortage of radiologists reading chest x-rays. Recently, AI algorithms have been developed and validated for chest radiograph interpretation and have shown high performance comparable to experienced radiologists for the interpretation of select radiologic abnormalities. Such results suggest that AI may potentially be used as an independent reader for triaging normal images from radiologists' work list. Anam and colleagues have developed and simulated an AI system for automated triaging of chest radiographs and suggested that AI-based workflow can reduce turnaround time for critical and urgent findings. However, due to the best of our knowledge, there is no study that evaluated AI to triage normal chest radiographs in a health screening environment. The purpose of this research is to investigate the feasibility of using AI to remove normal chest radiographs from the work list for chest X-ray reading in a health screening environment in a simulation study. We've suggested a workflow where AI identifies normal chest radiographs with high sensitivity, and radiologists review only the abbreviated work list and evaluated how it affects the performance of the readers. For the simulation, we've included participants who were enrolled from 3 secondary hospitals in South Korea: Boramae Hospital, Gil Medical Center, and Konyang University Hospital, who were enrolled between January and December 2018. We've excluded 370 patients whose interval between chest radiographs and chest CT exam was more than 1 month, and a total of 5,887 patients were selected as the final study population. And of these patients, 480 patients were randomly selected for reader study. The AI algorithm used in this study is a commercially available convolutional neural network developed by Lunit. The network is a variation of ResNet and is designed to output the probability for the presence of select 11 lesions, including lung cancer, pneumonia, pneumothorax, and tuberculosis. 2 thresholds for normal triaging were selected in the internal validation set. Sensitivity-weighted threshold was the threshold at which none of the visible abnormalities were missed in the internal validation set. Triaging-weighted threshold was the threshold at which none of the images with clearly visible abnormalities were missed, and the cutoff value was higher than the sensitivity-weighted threshold. 9 readers participated in the observer performance test and included physicians, general radiologists, and thoracic radiologist group. For the reader study, OPT dataset were randomly selected from the whole dataset. The readers were asked to identify whether referable thoracic abnormality was present, and if present, select confidence rating from 1 to 5. The reader study was conducted in 2 separate sessions, one without AI and one with AI. The reference standard for the whole dataset was set in 2 separate stages. First, one of the 3 expert thoracic radiologists identified patients with referable thoracic abnormalities using chest CT and clinical information from EMR. Referable thoracic abnormalities were defined as abnormalities requiring further diagnostic evaluation. The expert radiologists also classified the abnormalities into one of the 11 categories. In the second step, 618 chest radiographs of patients identified as having referable abnormalities were further reviewed by 3 separate board-certified radiologists who marked whether the image contained visible abnormality. Visible abnormalities and clearly visible abnormalities were defined as abnormalities marked by abnormal by at least 1 and 2 reader respectively. In our analysis, percentages of normal chest radiographs filtered out and chest radiographs with visible and clearly visible abnormalities removed by Triage AI were obtained. The change in reader performance for reading with AI triaging versus AI assisted reading and reading with AI triaging versus reading with AI assistance were compared using McNemer's test. And here are the results. In the whole dataset, 6.9% and 3.9% of chest radiographs were positive for visible and clearly visible thoracic abnormalities. 0.4% had lung cancer and 0.3% had pulmonary tuberculosis. At triaging efficiency weighted threshold, 42.9% of normal chest radiographs were removed at the cost of erroneous removal of 3.5% and 1.8% of chest radiographs with visible and clearly visible abnormalities. At sensitivity weighted threshold, 19.7% of chest radiographs were removed at the cost of erroneous removal of 1.2% and 0.9% of chest radiographs with visible and clearly visible abnormalities. So you can see that there is a clear trade-off between increasing sensitivity and the percentage of normal chest radiographs that are removed. At triaging efficiency weighted threshold, we've missed 14 abnormal cases due to normal image triaging, and we included ILD, bronchiectasis, rib diseases, and other congenital lung diseases. In the sensitivity weighted threshold, we've missed 5 cases including rib disease, other congenital lung disease, and 2 clinically non-significant radiologic abnormalities. At both thresholds, we did not miss lung cancer and pneumonia due to normal image triaging, which are the 2 most important target diseases in the health screening setting. In the OPT study, AI triage significantly increased the specificity of average thoracic radiologist, general radiologist, and non-radiologist physician without decreasing sensitivity. This suggests that with AI-based normal chest radiograph triaging, unnecessary recall may be reduced. So here are the conclusions of this study. We've simulated using AI to remove normal chest radiographs from the radiologist work list in a multicenter health screening cohort data and potentially demonstrated that AI can be used at a tailored cutoff to decrease radiologist workload. As a result of normal triaging, diseases not included in the AI training could be erroneously classified, so clinical settings should be carefully considered when implementing AI as a triaging tool. AI with broader range of disease coverage may demonstrate better results in the future study. Thank you for listening to this presentation.